Hello, everybody, and welcome to St. John's Health Center and John Wayne Cancer Institute's Be Inspired series webinar. This is the 6th webinar that we have done this year. We took a little hiatus from March to June, as did the rest of the world, but we're back and we're very excited to hear the speakers today. While we've retooled how we communicate because of COVID-19, we have found that doing webinars allows us to have many more people on the call and people that are coming from all over the city and the country. So it's been fantastic to be able to share our message about the work that we're doing at John Wayne and St. John's Health Center. And we're really happy to have you on the call today. We will be recording the call today, and the link is available for you. If you'd like a copy of this webinar, please just let us know. I want to give you a few ground rules for the call so that we're all able to hear well and you're able to ask questions of the doctors after they speak. All the participants on the call will be muted so that we can hear the speakers. Because you are muted, you will not be able to hear, we will not be able to hear your voice if you want to ask a question, and it's important that we hear your questions. So we'll ask you to type your questions into the chat function on the webinar. The chat function is located at the bottom center of your screen. It looks like a little thought bubble, and you can type your questions in there. I'll see those questions and I'll ask the physicians after they speak. If you don't have your questions answered at that time, please do not hesitate to give us a call or email us back and let us know that you have a question, and we will make sure to get the doctors to respond to that for you, and we'll get it back to you. We have a very interesting hour in front of us. We'll learn about the John Wayne Cancer Institute and St. John's Health Center's work in cancer treatment and research, our vision for the future, and our pivot to COVID-19 treatment and research. We will also hear from 2 specialists and researchers about the work in breast cancer and benign breast disease, and the role genetics plays in women's cancers. You will hear about new treatment options, research, and prevention. You have received bios on our speakers in the mail, so my introductions will be a little bit shorter today, and I'm very honored to introduce them. Our first speaker is Dr. Stephen O'Day. He's the Executive Director of the John Wayne Cancer Institute and Cancer Clinic at Providence St. John's Health Center. He's also the Regional Director of Research and Professor of Medical Oncology. Dr. O'Day is recognized as one of the preeminent melanoma and immunotherapy specialists in the world. He's been a principal investigator on seminal research projects that brought immunotherapy to mainstream cancer treatment. And this has changed the way certain cancers are treated worldwide. Dr. O'Day?
Thank you, Jean, for that nice introduction. So I'm really excited today. I only have about 10, or actually Jean told me 11 minutes before we started. And the main program I'm very excited about is to introduce you to Dr. Grumley and Dr. Gordon, who are really pioneers and leaders of our breast cancer, women's health, and medical genetics program. And I just want to set the stage a little bit about these programs of excellence that we're developing, and so a little bit of the history of what we're doing. I am a practicing oncologist. I'm in the trenches every day. I'm a clinical researcher. I understand the aching need of better treatments for patients, as both Dr. Gordon and Grumley do, and so I'm very excited to have them present to you some of what they're doing. You should know that this is a very pretty special place. And about 2 years ago, I became the executive director and leading a really talented, small but really talented group of clinicians and researchers at the John Wayne at St. John's. And it's really been an extraordinary couple of years as we've sort of reshaped our vision and pivoted in cancer to really see the world the way it is, which is in cancer, the field has progressed so much on the clinical and research level, and our history is fairly unique in the sense that we were an academic UCLA surgical oncology program that pivoted into a community hospital in 1991. It was a huge experiment and everyone thought it wouldn't work, but basically what we've done is brought the best of academic medicine and community-based cancer care to patients in families in need. And I'm really, really proud of that history. And what that involves is putting together unique disease teams that are world-class. Just because we're not in an academic center doesn't mean we can't put together world-class, literally world-class surgeons and medical oncologists and medical genetics physicians working together around the patient in a very small space that essentially promotes cross-fertilization and elevates the level of care. So we've done that in melanoma, in brain tumors, in GU tumors, and now we're fully putting our emphasis into breast cancer, medical genetics, and women's health. And that's what you're going to hear about today. But what all these programs involve is bringing world-class doctors together and bringing the best possible clinical trials to these physicians, as well as translational projects in the laboratory. And it's that synergy that is magical and that has really allowed us to give a much bigger imprint on not only our patients' care, but our contributions to the scientific literature. And just to end these comments, I want to just say that we have used that same model in our pandemic of COVID and literally pivoted this concept and brought together, with the leadership of our cancer team actually, we brought together the best of critical care colleagues, infectious disease colleagues, pulmonary colleagues that are the primary caregivers of the sick COVID patients. And we rallied our research team, our cancer research teams around that. And as you may be aware, at St. John's, we've literally helped advance the knowledge in COVID. And we've been part of 4 or 5 pivotal trials that have led to the approval of remdesivir and steroids, and also more recently, more novel agents. And soon with spike antibodies, and even we're starting vaccines shortly. So even though we're a small hybrid academic community-based hospital, this level of expertise we have in cancer has been pivoted, and the immunology behind cancer, which is driving the field, has been a huge part of contribution to the COVID data. And I'm really, really proud of this institute and St. John's for doing that. And we put probably about 80 or 90 patients on pivotal trials in the last 6 months. We've changed and helped to change and drop the mortality rate from sick patients. And now we're actually started our first outpatient programs to actually give spike antibodies to patients, a one-time antibody that may prevent patients who have mild symptoms from becoming sick and hospitalized. At the same time, we've kept our hospital open. We're doing surgeries. We're taking care of patients. Our cancer program has been busier than it's ever been. And I'm just really, really proud of the team at our institute and the doctors and researchers in conjunction with the administration of the hospital. So I'm happy to answer questions. I think there's a brief period of time about this, but I think what we really want to emphasize is these programmatic developments. You're going to hear about breast and women's health and genetics. That you have tremendous ability to impact these programs in their critical growth phase, as well as the patient care impact with your support. And so I really want you to think about that kind of impact. And believe me, we are putting together the top talent, and the recruitment process is high bar, and we need to be high bar because we're in a competitive West Side cancer environment, and patients have lots of options, and they want centers of excellence, and they want doctors who are focusing on a disease and have access to the best surgical, medical, clinical trials, and translational research. And also psychosocial care and genetics now are intricately involved across all tumor types, but particularly breast and women's health have sort of led the way in some of these family genetic syndromes, as well as tumor genetics in the actual cancer. And so you're going to hear a lot about that today. So I think I'll stop there, and I'm happy to answer any questions, and then we'll get on to the real show.
Thank you, Dr. O'Day. That was great. And I do have a number of questions. Let me start with the first one. Can you speak a little bit about the specimen repository that we have at John Wayne Cancer Institute and how that has added to our research both in cancer and COVID?
So that's a great question. So we have one of the deepest, largest biorepository specimen centers in the world, actually. And this was because Don Morton back in the 1970s started in the melanoma program collecting both tissue and tumors. So, and we put in several $1 million a few years ago to get all new freezers and to annotate all of that database. So that's a huge resource from the past that is very helpful even in the present when new biomarkers or scientific markers are discovered that might be used. Having said that, that history has led us to develop in sort of more current times, each disease is developing their own tissue and biorepository databases, and that's going to be a big part of how we go in the future. So we have a very long historical database that's used worldwide in collaborations, but we're also developing our state-of-the-art biorepository specimens around diseases. So melanoma and breast and GU, and each is going to have their own repositories. This is really critical because science can be done within our own walls, but given how small we are, the beauty of these biorepository bases is that we can actually work with the best science around the world by sharing these samples and the databases. And that's the collaboration of science.
And that was the next question, actually, is really about collaboration. We're a small organization, really, but we're huge in terms of how, how we work with people worldwide. Can you speak to that for just a moment about our collaboration?
Yeah, I think, in 2020, big institutional walls can actually be barriers because what happens within one big institution, even the best of the best, is there's siloing effect and there's competition. And so it can be great, but when you have a smaller physical space, the walls are not as containing. And I think it's when you attract world-class experts in their disease, they're obviously globally in touch with others in their field. And so that's the beauty of the collaboration. We're not stuck with, we have science here and we're developing it. And obviously that's a primary focus of our scientists to work with our data and our specimens. But, we have collaborations right now around COVID with the National Cancer Institute, National Institutes of Health, with our colleagues in Providence up in Portland and Seattle. So the freedom to collaborate is really where science takes you, because you have to follow the science, as they say.
Great, thank you. We also have a very well-known fellowship program at John Wayne. Can you speak to that a little bit, please?
Yeah, this is I think one of my great prides. When you step out of a pure academic situation, on the medical side, it can be very difficult without a medical school and a residency program to actually train medical fellows. On a fellowship level, on the surgical end, though, as long as we have an affiliation, which we do, with an academic center, you can train and develop these training programs. And one of the big features of what Don Morton left UCLA in 1991 was, could he bring his surgical oncology training program, one of the biggest in the country. And people were worried that the fellows wouldn't come if they were leaving an academic center. And yet it's the talent of who you have with your team, your clinical team, that attracts fellows. And so he was obviously able to do that. So we have one of the largest surgical oncology training programs in the country, I think second only, with 4 fellows a year. It's a 2-year program, so we train 8 fellows over 2 years. And that's, I think, just Memorial Sloan Kettering and MD Anderson have larger programs. We're one of the few, if only, fellowship program that's not part of a large university hospital. Janie is in the process, in addition to that program, hoping to build a breast fellowship program, and she'll talk a little bit more of that. So it's one of the great, I think it brings great value added to our mission of teaching and the legacy and giving back. And I don't know, the excitement around being around young, bright trainees in that are highly subspecialized, it makes me want to come in every day.
That's great. Thank you. And I have one other question. Where does somebody access the outpatient clinic if they have COVID, or you were talking about an outpatient clinic for COVID? Can you
Yeah, I mean, so we have a COVID team now that is run by Dr. Fisher, Trevin Fisher, and Anna Rocha, who's a nurse practitioner. So we can give people contacts to that. But any questions, anybody that is affected personally, a loved one, a family member, you should be reassured that St. John's has probably one of the most advanced COVID treatment program in terms of standard of care, respiratory support, ECMO, and then clinical trials for patients who get very, very sick. So we want to know about anybody that you need us to help treat. What I was referring to also now, we have a clinical trial for anyone that's positive, whether they have symptoms or not, to have access to, particularly if you're older or have other illnesses, whether you have symptoms or not, a one-time infusion of what you've heard in the news called the spike antibody, which may neutralize the virus. We have that trial open, and you would come through the emergency room as a one-time visit, and then you recover after that at home, and we come through visiting nurses and monitor you. So that's a wonderful program. Very few, I think we're one of the few, if only in the city, to have this program available. So that COVID team can get anybody who's test positive or has risks or has mild symptoms if they want access to a cutting edge clinical trial.
Fantastic. Thank you very much, Dr. O'Day. Appreciate that. Our second speaker today is Dr. Janie Grumley. Dr. Grumley is the director of the Comprehensive Breast Center at St. John's. She's a surgical breast oncologist who focuses on breast cancer and benign breast disease. She has special training in oncoplastic breast conserving, I'm having a little hard time with that today, surgery, and interoperative radiation therapy techniques that preserve the appearance of the breast after surgery. She knows how to beat the heat of a hot summer day in Los Angeles as well. She spends time in the ice rinks with her kids who play hockey and ice skate, though we do hear that she's the fastest skater in the family. So that would be fun to see. We're looking forward to hearing about your work, Dr. Grumley.
Thank you so much for this time. I'm honored to be here, actually. It's been about 2 years since I set foot here and started my position here, and it's been a very exciting 2 years. It feels like it was just yesterday when I arrived, but I feel like when I look back and reflect on what we've been able to build in this 2 years, I'm truly honored to have had that position and the help that I've gotten from everybody here, especially Dr. O'Day and all the other collaborators. You know, and when we think about what was it that I wanted to build, or what was the vision for the breast program, I think there are three main pillars that we wanted to really focus on. You know, we wanted to focus on patient care, obviously, because we're here to take care of patients. We wanted to focus on research because you need to be innovative. You need to push the boundaries so that you can make tomorrow better. And then we wanted to teach the future. We wanted to make sure that what we were learning today translates to tomorrow and the younger generation. So I'm going to focus on those three things, but let's start with patient care. It comes with a philosophy. You know, everybody has a philosophy in how you take care of patients. And one of the things when I reflect on what is the philosophy that we want here at St. John's, and it's really echoed throughout St. John's as a health center, is that we want to take care of patients. We don't want to just treat patients. There's a big difference between taking care of somebody and treating something. When you treat somebody, you know that there's a treatment, I'm going to give you a treatment. But when you care about somebody, that is a completely different approach. You get to know them, you understand their needs, and you also present them with all the possible options to help them make the best possible decision for themselves. And that's what we really wanted to focus on in our breast program. One of the things that you want to think about are, how do we make it easier for patients? How do we coordinate their care? And I think that's always been a huge frustration when I talk to patients who have undergone cancer care or seeking cancer care, is Where do you start? How do you navigate through this entire thing? And so we wanted to ease their way. We wanted to make sure that it was an easy process for them to come in and everything is taken care of for them. So we have put in place navigators. That's basically their best friend for most of our patients. They know who to call. They know who to ask a question to if they need something. They know somebody's looking out for them and looking out for their results and making sure that everything is coordinated for them. We bring all of the physicians together in a multidisciplinary clinic. So instead of you having, as a patient, travel from place to place and park in different places and come to different appointments and coordinate, we just bring our physicians together. And what's so beautiful about that process is that not only do we get to see the patients together, but we also get to communicate with each other. And that's such an important part of medicine these days, is that communication between the provider and the patient, but also amongst the different providers. There's so many things going on, and we don't want anything lost in translation. And being able to wrap our arms around the patient together, I think really helps us coordinate our care and allow the patients to feel like everyone is on the same page and we are taking good care of them. We also want to bring novel things. We can't be doing the same thing from 10 years ago. We have to bring in new techniques, and that's where we brought in oncoplastic surgery and intraoperative radiation therapy, and that's completely changed their options when it comes to breast cancer care. And we're bringing in other surgeons and other providers that are also going to add new things that they've learned in their fellowships or in their training programs in order to enrich all the options that we have for our patients. We want to complement that with genetics. That is such an important part of treating patients today, is how do we personalize what that person needs? And you can't personalize if we don't know what your genetics are or what your risks are. And so having Dr. Gordon in our clinic has just been phenomenal to be able to answer those questions and collaborate and help patients understand, if you don't have that genetic mutation, we can go down this avenue. If you do, here are some other things that we have to consider. And that is all part of making good decisions about their care. We want to add the complementary, and Becky has been great. We were blessed with a lot of foundation dollars that have helped support a lot of the programs that we can provide for our patients, including nutrition. That helps them get through treatment, helps them with prevention of breast cancer. There's stress relief, there's mindfulness, there's yoga that's being offered, and there's so many other things that we can provide for our patients, and we're always looking for great ideas to help complement the care that we can provide. Psycho-oncology has been the newest addition. We're so excited to have Dr. Nathan, who is now with us, to provide the psycho-oncology care, which I think is so important. There are so many women that say, oh, I don't really need a psychiatrist, but once they get a chance to actually sit and reflect, it's amazing how much her practice can actually help with coping, for them coping with just the cancer diagnosis, but also life in general, under all of the stress that we are under. To add cancer on top of that, you can just imagine what stress puts on those patients, and we are so lucky to have that program here. So we really want to just help patients understand what it is that they have to deal with. What are your choices when it comes to treatment plans? One of the biggest emphasis that I always teach to my fellows and our entire clinic is to educate. It is so hard to make a decision about what to do if you don't know what the choices are and you don't understand the choices. So we spend a lot of time making sure that patients understand their diagnosis, making sure they understand what are the treatment options, what are the downsides, what are the benefits, so that they can make the best possible decision for themselves. And that's how we come up with a personalized treatment plan. One disease can be treated a lot of different ways, and in different patients, they'll pick all the different treatments, they'll have different takes on which is the right one for them. And so we really want to focus on personalizing what it is that patient needs and what that patient will tolerate, and work with them to get them to the best health possible. And then we want them to thrive afterwards. So even part of clinical care is not just the actual treatment part of it, but years later. We want you to thrive. We want you to feel like yourself. We want to be able to provide you with the reassurance that we're there for you, not just during the treatment, but for years later, because patients do have anxiety about, oh, is this cancer again? Or, oh, is this something else that I have to deal with? And we are there to provide that long-term friendship and that long-term care so that we become family. And that's what we want to be for our patients, is that family. Now, that's the patient care part of it, which I love. I mean, that's what made me want to be a physician, is to take care of patients. But in order to really take care of patients, you want to have a significant amount of research, or at least I have this love for research. Why? Because we can always be better. If you think about what breast cancer care looked like when I was a medical student, it was pretty limited. We gave chemotherapy to a lot of patients. We did a lot of mastectomies. We removed a lot of lymph nodes. And sometimes we didn't know why that didn't work. Now, fast forward 15 years or so, and it's completely different. We have so many different treatments that we have available. We have so many tools to help us decide who needs what and who doesn't need what. It is truly amazing. It really speaks to how breast cancer has been one of the diseases that has had the financial support through research, through grants, to actually make a huge impact on care. And so now today, it looks very different. If we screen a patient, they can get an early diagnosis, they can get a partial mastectomy, they can get intraoperative radiation therapy, they can just go on endocrine therapy. It looks completely different than it did 10 or 15 years ago. And I'm just excited to see what it's going to look like in another 15 years. Imagine what we can do. I love research because it is kind of our way of dealing with a problem. There's a problem in front of us, and our brains are amazing at fixing that problem. And so I love the process in which we can and try to do that. And our focus here at John Wayne is really about personalizing care. How can we better personalize what that person needs? How many times do I hear in clinic, how do I know it's going to work in me? How do I know I need that? How do I know if it's going to be okay if I don't do that? Well, I sometimes can't answer those questions. So we love kind of looking at research to see how can we answer those questions. Right now, some of the current studies we're looking at is, well, who doesn't even need a sentinel lymph node? Maybe we can look and find ways to decide before we even do a surgery that this isn't something that this person needs at all, because it's never going to show us anything on it. So why do something if it's going to only cause risk without the benefit? So we're looking right now at ways in which we can maybe predict who actually doesn't even need a procedure versus those that do. We want to look at ways in which we can figure out, intraoperative radiation therapy is a selected way of treating breast cancer. But why does it work? Nobody's ever looked at it. We've done it, but we haven't really looked at why does it work. Is there something molecularly that changes when we do intraoperative radiation therapy? And this is why it works so well, because conceptually, it's a lot less than what we normally do. So why would this work? And so looking into that might actually allow us to see if there's other ways in which we can use it, whether it's in other diseases or it's in more advanced diseases or something that we haven't used it in. And so this is what we're actively looking at, is how can we personalize what a person needs, and how can we personalize our treatments to the specific things that may this technique may be useful in. And so that makes me really excited to think about what the possibilities are. And I'm so grateful for the money that has already been put into the John Wayne Cancer Institute, because we have made huge leaps and bounds in the years before. And I can't wait to see what we can do with that in the years to come, because I think we have some talented physicians. We're putting together a great group of minds, both in the research side and in the clinical side, to help us kind of push the boundaries and see where we can go with this in the future. And just to kind of echo what Dr. O'Day said, it's lovely to have none of those silos here. People are so collaborative. You can constantly bounce ideas off of each other and, think about ways in which we might be able to use this in one disease, and how about the other disease. And that collaboration is so important, because that's how we can actually come up with new ideas. If you just kind of walk down your hallway and just think about your own disease, you're going to miss a lot. And I love the fact that we are so collaborative here and have been able to work well together. The last thing that we really want to focus on, and Dr. O'Day touched a little bit on, is our fellowship program. I think of education as the most powerful way to change the world. We can only do so much by taking care of the patients around us. But when you teach the next generation, you have that ripple effect. They go out and they've learned what you've tried to teach them and the ideas that you've instilled in them, and they make it even better. So our reach, our dollars that kind of train the people that are here actually extend so much further than the boundaries of St. John's. It goes to other places in the country, other countries even. And we can spread ideas and we can spread kind of that education. One of the questions I get a lot of is, why doesn't everybody do oncoplastic surgery? It's because we're not teaching it. If we don't have a ton of fellowship programs that are teaching it, it's really hard to spread that technique. And it's not something that you can just read online or go to a weekend course and say, oh yeah, I'm going to go home and do this now. It's really hard to teach something if you don't actually have them intimately involved in a formalized teaching program. And so we've had a breast fellowship here before. Unfortunately, that has not survived the transition, but I think it's probably an even more exciting time now because we have so much more to offer a fellow who comes today. We can teach them some of these novel techniques that they're not getting in other places. We can teach them about intraoperative radiation therapy. And I think it's just going to be better for tomorrow. So I'm super excited. We've got our application in. I'm going to keep my fingers crossed and hopefully we have a fellow in the near future. But definitely, you know, we can't thank enough the support that we've gotten from Foundation to fund these crazy ideas that we have that sometimes turn out to be amazing things. So I thank you for your time and I'd be happy to take any questions.
Thank you, Dr. Grumley. Really interesting. And we do have questions. Someone asked, what is oncoplasty and is it available at every breast center?
So oncoplastic surgery is the use of plastic surgery techniques to take out cancer. It was kind of a novel idea towards the end of, well, probably the beginning of 2000s. So basically, you know, my mentor, Dr. Silverstein, who is a breast surgeon, had a plastic surgeon in his office, and they kind of came up with the idea that, well, you know, I take out the cancer in these traditional ways and leave this huge deformity and a defect. But you take out a whole bunch of breast tissue in a breast reduction or a breast lift, and it looks beautiful. So why are we not combining those two ideas? And that's basically what that is. So at the same time, when we remove the cancer, we can actually do it in such a way that we can reshape the breast and often provide a little lift, but that minimizes the deformity and that can then preserve the breast. And we've actually been able to publish at my previous institution, being able to decrease the number of times we have to go back for a re-excision. That means we didn't quite get it all the first operation, you have to go back for a second operation, or decreasing the risk of having to do a mastectomy, which then would open up the door of needing reconstruction and implants and multiple operations. So it really kind of opens the door for us to be able to take care of patients in a slightly different way.
Thank you. The next question is about intraoperative radiation. And is this something that is in lieu of radiation after surgery or in addition to?
So in traditional breast surgery, when you do a partial mastectomy or a lumpectomy, you take out the cancer and then you treat it with radiation, and it typically takes anywhere from 3 weeks to 6 weeks. So what we've noted, or what we've seen through research, and it was a randomized controlled trial where they treated half the patients with standard and half the patient with the single dose. Those patients were low risk patients. So we're trying to eliminate unnecessary treatments in these patients because they don't have a high risk cancer. What if we just treated them with 1 dose of radiation at the time of surgery? And what they found over time, and this has now been a very long study, it started in 2001, what we're seeing is that those patients actually have fairly similar recurrence rates. So patients are not, you know, or we're not seeing more recurrences just because they're getting less radiation. But what we're doing is we're actually just radiating the area that needed to be radiated and avoiding areas that don't. So just like everything in medicine, we do have side effects to everything we do. But if you have a very small cancer, we can minimize those side effects by doing a little bit less, but still maximizing the treatment. In most of those patients that we treat with intraoperative, they do not require additional radiation, but they have the option of it because sometimes we don't know how big or how aggressive the cancer is until we take it out. So it doesn't burn the bridge for additional radiation, but about 75% of the patients that we treat with intraoperative will not need additional radiation.
Great, that's very interesting. And then the last question is, how would somebody access nutritional counseling or seeing the cancer psychiatrist?
Yeah, so it's very easy. Anybody who needs anything can actually call our office. Rochelle is our nurse navigator right now. So you can go through her, go through myself, go through the office itself. We can definitely get anyone set up for all of those services available.
One more question just came in. What research developments or advances are you most excited about over the next 1 to 3 years?
Well, I think there's so much out there. I think there's a lot in the medical oncology world. Immunotherapy is a very exciting up and coming, I think, area of research. We do want to know if this has kind of a long-lasting effect, and it's really targeted at the most challenging cancers right now. So I think that's an area that's probably going to explode in the next little while. I'm excited. I personally am excited about intraoperative radiation therapy. I think there's going to be some more expanded uses for it. I think we'll be able to use it in different ways. But I also think that personalizing medicine is going to be the kind of wave of the future, figuring out who actually needs what and figuring out if they're responding before we get to the end of treatment, right? If you get chemotherapy, we kind of want to know it's working along the way instead of getting through the whole thing and then doing surgery and saying, oh, it didn't quite work as well as we like. So I think techniques in which we might be able to better ascertain the effects of each treatment along the way will help us guide what that patient needs. And I think that's probably where we're headed in the next little while.
Great, thank you, Dr. Grumley. Very interesting, appreciate that. Our third speaker today is clinical geneticist, Dr. Ora Gordon. Dr. Gordon is nationally recognized expert in hereditary cancer. She's a board certified in both internal medicine and medical genetics, and she's fellowship trained in integrative medicine. She is the regional medical director of the Center for Clinical Genetics and Genomics for Providence, Southern California, and is a professor of genetics at both John Wayne Cancer Institute and at the UCLA Geffen School of Medicine. Dr. Gordon is the author of an award-winning book for women facing genetic risk for breast and ovarian cancer called Positive Results: Making the Best Decisions When at High Risk for Breast and Ovarian Cancer. Dr. Gordon?
Thanks so much, and it's absolutely my pleasure to be here, and all of you for joining us in this Lunch and Learn. I'm assuming you're having lunch. I can't see that, and I know you're learning, and really appreciate all of the comments from Dr. O'Day and Dr. Grumley. So in kind of closing out today's discussion, I think that it's such a great way to talk about St. John's and the work that we're doing both clinically and at the John Wayne for our clinical research and translational research to sort of finish. And I have just a little slide that's a visual that I feel like sums up kind of the things that we are talking about here today. So, excuse me. So everything that you've already heard, right? The top of this, what are we looking at? These 3 levels of how do we care for all of our patients. When a patient presents with breast cancer and all of the cancers that we treat at our center, it's targeted treatment. When we talk about genetics, sometimes what gets confusing is people are now getting a lot of molecular or genetic information that will help in terms of the precise decision-making of what's the best therapeutic for them. So we look at these things together. It's the genetics of their tumor and the genetics of their whole person. And in both of those roads, are there ways that we take care of them differently? Every patient who is a new patient to the multidisciplinary clinic for breast cancer gets assessed, do they need genetic testing. Not all of them do, but being able to do that as part of that initial point of care to help the totality, the holistic approach to their treatment is really an enormous differentiator. And it allows for all of the information up front to both plan for the most appropriate surgical intervention and also provide a lot of often reassurance that, you know, the women, they come in, everybody is tremendously anxious and very often feels like, oh my gosh, I just, you know, I want to get rid of all of this risk, especially if there's family history. But we can then tell them, you know what, there is no identifiable hereditary mutation. You don't carry what most people now are familiar with, the BRCA gene, but in fact, there are many other genes, and that we can help them then modulate and say, you know, what is the best treatment for you? Conservation may be absolutely the best therapeutic choice for you, and to help guide that in a way that is tailored to them individually and also a watershed to their family. So we have targeted therapeutics that are both approached based on their molecular profile or the tumor profile, and then also what all the cells in their DNA, all of their body carries. It's this tiered approach to then risk assessment and prevention. So the risk assessment is risk to them for future cancer, risk for cancers that may not have been even on radar if we identify that there's a hereditary susceptibility, and then prevention. And this is again where the totality of care, being able to bring together our wellness programs, our nutritional intervention, medication, surgical and screening preventions, if there are other cancers that individuals are at risk for, to be able to plan that as a forward, as their lifetime of kind of care as a continuum. And of course, in the world of genetics, there is nothing that is not more family oriented than your family tree that you see behind me, and kind of that risk that we see to other members. And so being able to assess for that and to appropriately engage everybody in terms of their health and their prevention is really part of the fundamental goals of care that we provide as in our breast program. I'd like to, though, you know, where I spend a lot more of my time is sort of flipping this pyramid, whereas the prevention is my approach as the first and foremost. And of course, treatment, if somebody has cancer, treatment is always going to be sort of the pointy end of that diamond, because that's going to be what matters, and the effective and most appropriate and most tailored treatment to that individual's cancer is essential. But pulling back a little bit, you know, if we identify somebody who has a hereditary cancer susceptibility because the first member of their family has gotten breast cancer at 35, to me, that's too late, right? What do we want? We want to identify risk before there's a cancer and do everything we can to intervene to prevent that such that there will not be a cancer. And so that's where a lot of our work now, is going in terms of both novel ways to identify people who are at risk and to tailor what is their specific risk, particularly for things like breast cancer. So there have been a few initiatives that we've launched as part of research and clinical programs that are really looking to broaden this out, to say in the general population, how do we identify risk before there's a cancer, and how do we modify a woman's risk so that she knows how best to take care of herself? So two exciting things that we've done in that regard and are also trying to look for. There is a whole nother, so now genetic testing, most people now are familiar with BRCA, which is often called BRCA. There are a dozen genes for breast cancer, and we can now and routinely test for between 80 and 100 genes for genetic susceptibility to all kinds of cancer, to breast cancer, to prostate cancer, to colon cancer, to basically pancreatic, melanoma. Every known kind of solid tumor has about 10%, some with a little more variability, of an underlying genetic risk that we could identify. So how do we find those individuals, and then how do we take care of them differently and better? We are looking to launch in our breast center, for example, for our screening, in our screening population, a tool which can identify, is there something about that person's family history or their own medical history that would make them appropriate for genetic testing, and be able to, at the time when they're engaged in this prevention to coming for their mammogram, to be able to get education and genetic testing if that's appropriate. To, again, make this ease their way, make this fluid, make this be able to get to the point where we know where that risk is and how do we take care of somebody differently. This is really a whole different approach to identifying risk than historically, which has been very narrow and saying you have to have this neon sign, extraordinary family history before anybody recognizes maybe there's something hereditary going on. This is pulling the lens all the way back and saying, how do we find in the population those who are at risk? There's another study that we have been involved with at St. John's that is to tailor for a woman who has, let's say, a family history or has had a prior biopsy or who has, breast exams and imaging that is very difficult to read because the tissue is so dense. How do we better define their risk? And we have a novel genetic test, a mechanism to look at their, what I call the nuance in their DNA, a genomic test that says you're on a bell curve and you're at higher or lower risk. You might have a family history, but all of your genetic testing is negative and your personal genomic milieu is very low. We don't have to be as aggressive. You don't have to be thinking about these extreme interventions. Or you're somebody who happens to be at the very tail of this highest end of risk, but don't have a family history. Well, we need to narrow our focus and we need to have high risk surveillance for you as the individual. And this is really what the transformation, and when Dr. Grumley talked about what we didn't know 10 years ago and where we are now, we have this for breast cancer, for prostate cancer, for colon cancer. How do we pull the one out who's at higher risk, and how do we reassure the many that they really are not at elevated risk? And so this is how we're transforming our care, not only for our patients with cancer, but then as a watershed for all of their family members, and then more and more into the more broader community to be able to figure out who is at risk and how do we take care of them. All of the services that we have for wellness and prevention matter and are important in terms of that long-term prevention, as are tailoring decisions about what kind of screening, surgery, and preventive medications are appropriate. So in closing, in terms of how I approach care to all of our patients and what my service kind of as an addition, both in the clinical and in the research domain, is really to start to integrate all of these different elements. The research component of determining how do we determine what is the best therapy based on the tumor, what is the best therapy based on that person's genetic risk, the best treatment for them, and then how do we identify that in their families and in the broader population in order to have the biggest impact on cancer prevention over time. And certainly a commitment to education is as important to me as I can only echo for Dr. Grumley and Dr. O'Day. It is an honor to be part of the training of this next generation. I think that they are extraordinarily well advantaged to be able to get the kind of the totality of educational experience when the fellows come through, and those who are interviewing, they are over and over, what do we hear? They can't believe the amount of services that we have in our program. They cannot believe the breadth of both translational basic science and clinical research, the extraordinary front line in terms of treatment and medical and surgical and radiation oncology. So it's a pretty extraordinary place to be able to work and to come to say that this is how we are making a difference on every day. And so I think that with that, I would just like to close and open the floor to questions for myself. There will be webinars. I just wanted to let everybody know, we're going to have much more detailed webinars that are specific, disease specific, or certain, focusing on certain types of care or certain aspects of cancer and prevention that will be going along as in-depth learning modules. And this really was to just bring forward some of the incredible things that we're doing in the places that we hope to go as our programs grow and develop. So I will stop here to take some questions.
Great, thank you very much, Dr. Gordon. And the webinars that Dr. Gordon is speaking about, these learning modules, and Dr. Grumley probably mentioned them as well, they will be on John Wayne Cancer Institute website, and we're very happy to send those links about those webinars, because they're starting next week, I believe, and there's going to be at least 4 on women's health and breast cancer that are coming up, and prostate cancer, and a variety of other topics that'll be coming up that'll be really diving more deeply into information about these diseases. So we'll get more information to you about that. But I definitely have questions for you. So I'll start with, is it appropriate to consult with you in regards to my 2 daughters' level of risk, given that both my mother and I have had breast cancer?
So I think that is a very good framework for saying it is appropriate to consult with us for any time you have a question. There is no question that shouldn't be asked and answered. And whatever the context of your concerns for your personal history, for your family history, is appropriate in terms of trying to get more information. In just speaking to that, when you have multiple family members who have had breast cancer, if you have family members who have had early breast cancer, that is if that is in yourself, all of those are indications to consider genetic testing. But I will tell you, the more we look, the more we find in terms of hereditary risk, and that the combinations of cancers, that things that may not appear to be going together may in fact all speak to a underlying risk, that you may have melanoma and pancreatic cancer together. You may have breast and colon cancer in a family or a person that's going together, and all of those. So it doesn't have to be everybody has had the same cancers. So the short answer is yes, absolutely. And the long answer is please always ask a question, no matter what it is, that we are here to help answer that for you.
Great, thank you. The next question is, I had genetic testing 15 years ago and was told that I don't have any high risk for breast cancer, though I have family members that do. Should I be retested?
So thank you so much for bringing that forward, and that certainly will be part of when I go into my in-depth talk on genetics and genomics. And again, if what we knew 15 years ago compared to what we know now, that has been a absolutely transformational change in that generation. The testing you had 15 years ago, I can guarantee is totally inadequate. And so what we have learned at that time, you probably would have had BRCA 1 and 2 testing. That test by itself has improved about 3 times. And now where we used to only be able to test for those 2 genes, we now test for 100 genes, of which a dozen are related to breast cancer. And then we have this genomic additional testing. So there's so much more richness in our ability to understand risk, as well as using models that will pull in all kinds of personal information, like what is your weight, how dense is your breast tissue on imaging, all kinds of things to, again, kind of individualize what your risk and best care plan will be.
Great, thank you. Next question, are there any studies on lung cancer and hereditary risks for it?
So there are a lot of studies on the potential for hereditary susceptibility to lung cancer. This is an area which, has been most vulnerable to exposure-related risk. There are a lot of different types of lung cancer, and certainly Dr. O'Day, if you want to speak to that a little bit. There's one known genetic susceptibility, which is interesting in that it crosses over both in terms of therapy and risk, and that's in a gene called EGFR. And so that has, with that and one very rare condition, have been the only ones that really have shown a identifiable clinical genetic susceptibility. But in families where there are multiple lung cancers, sometimes we screen the unaffected person for lung cancer susceptibility, much in the way we do for people who have a lot of tobacco history.
Okay, thank you. This looks like it could be a question to all of you. So, and I may not pronounce this very well, so excuse me. How effective has Xeloda or capecitabine been in eliminating microscopic traces of malignancy?
I'm a medical oncologist, so I probably should take this, although Janie could answer it equally as well. And that's the power of our interdisciplinary, because this came up at one of our breast tumor boards just this week, and we had 3 or 4 medical oncologists and multiple surgeons and the fellows, and we had a robust discussion. So this is a type of oral chemotherapy that has been used in breast cancer for many, many years. It was part of the original CMF regimen. It's a 5FU based regimen. Now this is a new oral version. But the reason I think maybe this question is coming from recently after what we call neoadjuvant therapy, where we give chemotherapy, not this chemotherapy, but some other therapies before surgery in higher risk women, particularly triple negative breast cancers or HER2 positive breast cancers. We're left with some residual cancer afterwards, and patients have, there's been a study with this, to whether adding this drug after surgery could reduce that risk and so much clean up any microscopic disease in the bloodstream. And it has shown to be a benefit in certain subtypes, particularly higher risk women. So I think that's probably what that, it's not for everyone, and it's complicated, the data on who best benefits, but certainly people with higher burdens of cancer after their surgery or lymph node positivity that have already had prior chemotherapy might be eligible for something like this.
Thank you. So while I have you, Dr. O'Day, I'd like to ask you this question. I'm going to also ask Dr. Gordon the question. Someone asked for all panelists, but I think it's great to hear from all of you about this. What research developments or advancements are you most excited about over the next 1 to 3 years?
Well, I think Janie spoke to it, and Ora did. You know, personalized approaches to practice are huge. And I think that has to do with understanding there's a whole surgical side to that in terms of minimizing surgeries when you can, or minimizing radiation in select groups of patients, and figuring out who that, or genetically, who's really at risk and who's not. That's a huge area in the coming years, so that we don't over-treat people, but we don't under-treat. So a lot of research around that. I would say more broadly in terms of the science, I think, as has been discussed, the field of immunotherapy, I like to call it a revolution. It truly was a revolution that really originated in melanoma, but now is spread to all cancer. Really being able to manipulate the immune system to eradicate even widespread, very advanced cancer is really at the forefront, and figuring out what are the immunologic deficits and how to make the cancer more vulnerable to the immune system. And the other is these genomics tumor, not just the hereditary genetics of cancer, but what we call the tumor genetics, the mutations of tumors that put a fingerprint on the surface of the tumor cell that may allow us to target cancer better than so crudely with chemotherapy, which was the old school. So I think targeted genomic or genetic approaches to the cancer combined with the immune approach, as well as figuring out not who to treat and who not to treat. But I think I just want to, and I'm going to let these two talk, but I just want to say I'm so impressed across our cancer center at the interdisciplinary dialogue that goes on, right? So the value of what Janie said is when patients have one-stop shopping, that's huge as a convenience, right? But even more importantly, that the value of the recommendations from the medical side is so much better when doctors are literally shoulder to shoulder in the clinic and cross-fertilizing each other. People underestimate that. So it's not just a patient convenience issue. It's the doctors who are open to learning from their colleagues, being vulnerable to put things out there. I don't really know what to do. That interchange across disciplines really ups the value of the care that's actually delivered. And it's easier said than done about whether you can accomplish this in bigger institutions. And that's the advantage we have at St. John's and the John Wayne. If you bring the right talent together who want to work together, small spaces are not confining. They're actually, it's really revolutionary. And so I never complain. I do complain. They know this. I complain about the cramped space and everyone has beautiful big facilities. Well, you know, small cramped space is magical in terms of if you bring the right people together that want to teach and legacy, bring research and the top care together. I think that's what we're doing, and it's pretty special. So you have a huge impact on us, our patients, our benefactors, people who give their time and talent and help us with this mission.
Thank you. And I just have one more quick question because it's 1 o'clock and I want to be thoughtful to our time here. Dr. Grumley, is it safe to come to the breast center during COVID?
That's a very good question. It's absolutely safe to come to the breast center. Luckily, we have not had a significant number of cases, at least currently in the hospital itself. The breast center is in the basement. We have not had any issues with COVID transmission down there. It is actually very important to still get your screening. October is coming up, so I do encourage everybody who is due to get out there and get their screening. As we've seen through COVID, we've had some delays in diagnosis, and that does impact what we can offer when it comes to care. So it is safe to come to the breast center. They have put in extra measures to make sure that they clean extra cleaning measures just to make sure that between patients we're not having any issues. We're not having significant wait times. Obviously our patients' health is most important to us. So it is absolutely safe to come, and we look forward to seeing you.
Thank you very much. And I want to thank you all for joining our call today. If you're interested in hearing more about the work that we're doing at the John Wayne Cancer Institute, we will be discussing melanoma and skin cancers on Tuesday, October 20th from 12 to 1. So we'd love to have you on our call. Please email us at the email that we've been sending you information on. You can just respond back if you're interested in joining, and we'll be sending invitations out for that as well. Dr. Grumley, Dr. O'Day, Dr. Gordon, thank you all for your time. It's just really appreciated, really interesting. And if anybody has any additional questions and we haven't gotten to them, please just email us. We will get back to you, I promise you that. Look forward to seeing you again soon. Bye-bye.
Bye, everybody.